Now I would like to call upon our next speaker, none other than Dr. Deepak Puri. Dr. Deepak Puri needs no introduction, but I would still go ahead and talk about him. He is a global chairman of Cardiomersion. He has been assistant professor at PGI Chandigarh, additional director CTVS at Fortis Hospital Mohali, senior director CTVS at Max Super Speciality Hospital Mohali. Apart from being professor in practice at Chandigarh University and chairman of ethical committee, his area of interest is off-pump coronary bypass in high risk as well as ischemic heart failure and uniportal VATS. He has more than 87 publications and has written chapter and book, presented more than 200 papers, apart from being organizing chairman of more than 20 international conferences. He has also received 8 travel grants and received several awards, including Most Trusted CTVS Surgeon, Asia GCC, Indian Icon, International Healthcare Professional, and Himotkarsh Himachal Shri. Please welcome Dr. Deepak Puri for his talk. We all are eager to hear.
A very good evening to all the participants from India, and also a very good afternoon to all the participants at Rome. Unfortunately, we were not able to meet at Rome this time, but I think that we'll make all efforts that we can be connected to all of you at Rome also. So once again, thanks a lot for participating in this Cardiomersion session. So today my talk is on comprehensive management of rapidly worsening ischemic heart failure, and I will be sharing my experience also. So everybody is quite well aware that heart failure burden is increasing across the globe, and most of the patients above the age of 65, they are at risk of getting heart failure. And in the Indian population, we get heart failure at a much younger age compared to the Western population. And it is seen that as you grow older, the risk of getting heart failure, it also grows. And it is an estimated risk that almost 1% of the patients they have heart failure in the 5th decade, but as you grow older to the 8th decade, almost 10% of the people population, they may be affected with heart failure. So I would like to share that the population of heart failure patients in India, it is quite different from the rest of the world. And apart from getting affected at a much younger age, it is seen that the Indian population is predominantly those patients who have ischemic heart failure, because they come to the hospital for treatment quite delayed, and it is seen that almost 21 million Indians above the age of 19 are likely to have a history of myocardial infarction, and the burden due to myocardial infarction in India is almost 60% of the heart failure patient, they are because of ischemic heart failure. And also it is seen that the mortality of the heart failure patients in the Indian population is quite high. 1 year's mortality is 31%, 3-year mortality is 45%, and 5-year mortality is 60%. So heart failure is coming up as a silent epidemic, and it has a great impact on the general population. And it is seen that the common risk factors causing decompensation of heart failure, they are excessive salt intake, some medications and arrhythmias, fever and infections, and alcohol consumption. Also it can occur during pregnancy also. However, the majority of the patients with deteriorating heart failure in India, they are because of atherosclerotic coronary artery disease, and we have to control the coronary artery disease right from primordial prevention to the primary prevention, and then we have to make the patients come forward for early diagnosis, and also we have to make sure that the patients they get timely interventions with the help of a heart team, and it is the team which decides which is the best intervention, whether it is percutaneous intervention or it is the surgical interventions. And then we have a group of patients who are stable, but these patients are also at a risk of worsening, and it is seen that the risk is almost 40% for cardiovascular death and repeated heart failure hospitalization. And also it is seen that apart from the medical management for heart failure, surgery plays a very important role in ischemic heart failure, and the medical management and the surgery, they are not competitors. Actually, we have to work as a team, and they are complementary to each other. And it is seen that the patients initially may be asymptomatic, and later on they may just present with an acute event which precipitates the heart failure. And once the patient undergoes any intervention, then it is seen that the patient may improve clinically, and the risk of mortality and rehospitalization may fall down for some time. But later on, as we see the natural course of the disease, it is seen that these patients have repeated exacerbation of the events, and then gradually they enter into a refractory or intolerant phase where the heart failure becomes advanced, and then they become candidates for transplant or mechanical assist devices or other devices like ICD and CRTD. So the worsening heart failure is something which is a great cause of worry. Because of the chronic worsening, it accounts for 80% of the heart failure hospitalization, and also 1 in 2 patients will be hospitalized again within next 30 days of the worsening heart failure event, and it is seen that 1 in 5 patients will die within 2 years of their worsening heart failure. So despite guideline directed medical therapy, patients they still remain at risk for cardiovascular death and heart failure hospitalization. And it is seen that even patients on quadruple therapy, they remain at risk of worsening heart failure. And it is seen that almost 14% of the patients on quadruple therapy had a primary event over the course of the trial, and it is seen that 1 in 7 patients they experience a primary outcome event despite confirmed use of quadruple therapy, which consists of ARNI, beta blockers, MRA and SGLT2. So apart from the 4 pillars of quadruple therapy, there is another drug, Verisuguat, which also helps in the rapidly worsening heart failure events. So this drug, it acts by stimulating the SDC and cyclic GMP pathways, and it increases the sensitivity of nitric oxide, and it improves the circulation as well as it improves the recovery of the patient. So by restoring the nitric oxide, SDC and cyclic GMP pathway, the improvement is seen in the pathophysiology, which improves the myocardial stiffening is less, hypertrophy is less, ventricular remodeling is less, and fibrosis is also less. And also it decreases the renal fibrosis, increases the renal blood flow. So the chances of renal failure also are less, and also the vasoconstriction is decreased and endothelial function also improves. So the dose of Verisuguat is increased from 2.5 in the initial 2 weeks to 5 milligram. It is doubled every 2 weeks till you achieve the standard dose of 10 milligram. And it is seen that almost 90% of the patient they achieve the 10 milligram target within 12 months. And also it is seen that Verisuguat has very unknown side effects and complications, and it is also seen that it can be even given in patients who have low GFR, and the chances of renal failure worsening is also almost negligible. And also it is seen that there is very little interaction between vericiguat and other drugs, and also the chances of having hypotension in patients with heart failure after giving vericiguat are almost negligible. So we can give in those patients who are having low blood pressure, we can give in those patients who are having renal failure. So it is relatively a very safe drug to be given for worsening heart failure. So those patients who end up with the end stage heart failure, they require a heart transplant. But as you know, most of the heart transplants, they are conducted in North America or Europe, and only sometimes you hear that in India heart failure is getting treated by a heart transplant. And also it is seen that the other things like ventricular assist devices, they are also very costly and beyond the reach of most of the patients. And apart from that, like we have the CRTD, which can be used for those having a delayed QRS, and we have the ICD. So they are relatively cheaper, and they are given to those patients who have the indications and who are not the candidates for revascularization. Stem cell generation has been studied for more than 2 decades now, but recently we have seen that now the focus is shifting towards the paracrine therapy, in which the extracellular vesicles and the exosomes, they can be isolated and given for the paracrine effect to induce new myocardial cardiomyocyte generation, as well as increasing the angiogenesis to improve the infarcted muscle. But still it is not yet available for clinical applications. So we talk about the surgical revascularization because most of the guidelines, they say that if the patient is having multiple vessel disease and if the patient is having low ejection fraction as well as diabetes, then they become the candidates of bypass surgery, and bypass is the best treatment option. So various studies have shown that if you compare the mortality risk between the medical therapy and the CABG, so as after a period of say few years, it becomes more and more apparent, and after 2 to 3 years, there is a drastically glaring difference between the outcome of patients put on medical therapy and the patients on surgical therapy. Like after revascularization, they have a better survival and the mortality risk is less. So this study, which was published in last year, it shows that the patients who had surgical revascularization, they had better long-term survival, and the results of interventions with percutaneous techniques, they are not clearly very like supportive of percutaneous interventions in treatment of the patients who have low ejection fraction heart failure, but they are very effective for those patients who have rapid decompensation, and because of the acute MI, and there is a like a culprit vessel to treat these patients, they can be effective. But we have to, a team approach has to decide which is the best treatment option for such patients. So if we talk about the revascularization, then whether we go in for a surgical revascularization or sometimes we go for percutaneous interventions, and many times we may have to resort for options like hybrid procedures, like some patients who have acute MI and they have low ejection fraction and there is a severe MR. So sometimes these patients may be benefited by like a culprit vessel revascularization by percutaneous intervention, and after that, once the MR reduces, then maybe later on they may be taken up for surgical revascularization. So the heart team decides whether this patient is suitable for percutaneous intervention or this is suitable for a surgical intervention or a hybrid procedure. And then similarly, in the long term follow-up also, like if the patient, they have their graft occlusion, or if the stents get occluded, then the heart team will decide whether they are suitable for a re-intervention by the percutaneous approach or by the surgical technique. Or most of the patients who have graft-free stenosis, they may be benefited better by percutaneous interventions. And it was 2 decades back, it was thought that maybe surgical intervention carried a much higher mortality risk, especially in acute decompensation with a acute myocardial infarction. So the operative risk at that time was, in most of the studies, it was almost 14%. And it was seen that if the surgical procedure was performed off pump, then the mortality risk was much lower. So in the beginning of the second millennium, we were doing most of the surgeries on pump, but then gradually we started shifting towards off pump. And in the beginning, like the acute myocardial infarction patient, when they were hemodynamically quite unstable, so we used to put the patient on pump, but we never used to give cardioplegia, so that the heart kept on beating, and what we call the perfusion assisted bypass surgery. And this kind of procedures were done initially, and after 2004, then with more and more experience of off pump surgery, after that we have been doing all the surgeries off pump. So it was seen that the mortality risk of post surgical revascularization was much less in off pump, and they had a better long term prognosis also. And most of the AHA guideline also, they started recommended that in a acute MI setting, if the revascularization is done by the surgeon who is competent enough to do off pump surgery, then it should be done off pump, and it would give a better outcome. And our own experience, we saw that most of the patients used to have a more easy post-operative recovery, and they used to have less renal complications, less neurological complications. And after this, I would like to say that when a patient has a acute MI and is rapidly decompensating, then we have to first assess whether this patient is suitable for immediate revascularization, or should the patient be first stabilized by guideline directed medical therapy, and whether there is enough viable myocardium present to give the patient a benefit of revascularization if we have to do a surgical revascularization. So various tools we have with us is the ECG, and then we do the echocardiogram. And if there is on echocardiogram, if we have doubt about the viability, then sometimes we resort to the PET scan or SPECT studies, and then we also analyze whether there is enough hibernating myocardium, or there is more stunned myocardium, and whether there is an infarcted myocardium. And if we feel that there is enough hibernating myocardium, which will again start improving once we revascularize, and sometimes even after revascularization there may be stunning of the myocardium, where the actual function may be even worsen for the next 48 to 72 hours, but after that the patient may start improving. Sometimes we have reperfusion arrhythmias, sometimes we have myocardial swelling also. Like initially when we used to do on pump, sometimes the heart used to swell so much that we had to keep the chest open, and we used to close it after a couple of days when the heart used to regress. But after we started doing off pump surgery, we don't find such problems, and most of the patients, they recover well, and the post operative period also is less stormy in these patients. And then echocardiogram is very important. We have to see the RWMI, whether there is myocardial thinning, and whether how much MR is there. And if the viability is doubt, then maybe the other viability assessment may help us in deciding whether we have to immediately revascularize or not. So here you can see these are the various features we must see in the echocardiogram, and then you can see that this was one patient recently. This patient was having tachyarrhythmias, and patient had severe MR. The ejection fraction was around 24%, and then this patient had recurrent ventricular fibrillation and cardiac arrest, and we had to revive by CPR. This patient then underwent off-pump CABG, and after CABG, this patient recovered well, and we were able to discharge the patient within 5-6 days. And here you can see that the MR is also regressed, and there is a marginal improvement in the ejection fraction, like it was almost up to 30% on the 5th post-operative day. And we expect that if there is like more hibernating myocardium, many of the patients with ejection fraction of 15%, they improve to even normal ejection fraction if they are operated on time. And then some people, they think that we should investigate the patient for viability more strictly, but however we initially used to do it regularly on the patients who had heart failure, but nowadays we go more by the echo, and only when we have doubt about viability, then we resort to these studies. And it is also seen that there are various other biomarkers like troponin. So if the troponin is very high, patient has had a recent MI, then we prefer to wait till the troponin levels come down, because initially when we used to operate the patient with high troponin, then the per-operative period was very stormy, and sometimes patient used to have recurrent refractory arrhythmias, and sometimes we had even LV rupture because the muscle was very friable, and the post-operative renal failure incidence and other things. I'll show you our own experience also subsequently. So then we also do the pro BNP studies, and pro BNP, like if it is very high and if the patient is relatively stable, then we may first optimize the patient with guideline directed medical therapy. If the MR is also very much high, then if it is severe, then we would like to optimize the patient to reduce the MR to at least moderate, because whenever we do surgery for severe MR patients, then the post-operative period is difficult, and most of the patients, they take more inotropic support, more number of days on ventilator, and the risk of mortality is almost higher, especially if they are having renal failure also. So I would like to share a couple of patients who had a very stormy pre-operative period. So this is a 80-year-old female. She had diabetes mellitus, hypertension, triple vessel disease, stable angina for almost 15 years, and then came suddenly to emergency one day with acute coronary syndrome. On angiography, there was a left main dissection, and the ejection fraction was 50%, and on table she started having VT and VF. So IBP was inserted, and we got a call immediately from the cath lab. So by the time we reached, the patient had cardiac arrest, and then CPR was started, and ongoing CPR was going on, and then we talked to the relatives. They were just not prepared. They didn't have any finances ready, and they were not even ready to give the consent. So somehow we convinced them. Then we talked to the management, and we got approval to take the patient without financial clearance. Patient had a Euro score of more than 70. There was pulmonary edema, and after intubation, like the anesthetist was having great problem in ventilating the patient. So with very high inotropic support, we opened up the chest and started cardiac massage, and then we because the patient was having complete heart block. We put a temporary pacing atrial as well as right ventricular pacing, and we did the surgery of the patient, and luckily the patient recovered after surgery, and then we also put the patient on Valsucoac, and this patient went home after 5 days. Although the patient was elderly, patient had a smooth post-operative recovery. In the follow-up, the patient has been now coming for more than 1.5 years, and the ejection fraction also improved to more than 35%. So here you can see that once the patient comes to us with a acute MI, so this is the condition of the left ventricle. So here you can see on the upper side, this is the left ventricle, and we have to very gently handle the ventricle, because we don't want to rupture the ventricle, because this is so friable that if you try to repair it, the sutures keep on tearing off, because there is no strength in the ventricular wall, and we have to keep the octopus stabilizer also at a distance from the infarcted area. And then here you can see we have put the intracoronary shunt, and now we are doing the LED anastomosis. And here on the other side, lower down, you can see the right ventricle. So this is beating, and the wall is also normal apparently compared to the left ventricle. So if the surgery is performed on time, then these patients, they have a very smooth post-operative period, and then they recover well. And most of the patients, they are coming to us. We have a almost 20-year follow-up of many patients, and they are doing quite well. Here you can see this is a very dangerous left main, like there is a trifurcation lesion, and it is a tight ostial, and you can see that such kind of patient, they can collapse anytime. And even when we take the patient for surgery, during induction, many times the patient crash. So initially we used to put an intra-aortic balloon pump and then induce the patient. But many times, like over the years, with more experience, sometimes we even do the surgery without the help of intra-aortic balloon pump. So this patient was 83-year-old, and troponin was more than 35. There was a critical left main, and ejection fraction was only 20%. And this patient, we did a bypass of pump, and then patient recovered well and is doing well on follow-up. So here you can see the right corner is also having a tight lesion. So this patient, another patient, this patient also had a iliofemoral peripheral vascular disease. So this patient had an ejection fraction of 25%, and with moderate PAH and nephropathy, respiratory failure, sinus bradycardia. This patient had hypotension after induction with severe PH, and IVP could not be inserted due to the severe iliofemoral blockages. So we open cardiac massage was started, and CABG was done. Once after massage and with high inotropic support, we achieved a mean arterial perfusion pressure of above 65, and this patient also had a dilated aorta, and the vessels were very thin. So this patient also recovered well, even without the help of intra-aortic balloon pump. So here you can see the diffuse disease in both the left coronaries as well as the right. And here you can see this patient was admitted in another hospital in another city. So they advised CABG to this patient after acute MI, but there was severe LV dysfunction. Ejection fraction was around 20%, and probably the cardiologist had thought this vessel to be the LAD, but actually you can see that the LAD stump, you can see on the top, the LAD is totally cut off just after origin, and this was the other vessel, this was not LAD. So once the patient came to us, we assessed the viability, and we found that there was hardly any viability in the anterior wall, because the patient had come to the hospital late, and also there was a delay of several days at the other hospital, and then the patient came to us. So we referred this patient to the cardiologist, and they did a percutaneous intervention for other vessels, and because the LAD artery was totally infarcted, so there was no point of doing a CABG in this patient. So what I want to emphasize is that it is a team approach where the cardiologists as well as the surgeons, they come together, they sit together and decide what is best for the patient. So here I'll share with you like our own series of patients who had decompensating heart failure, ischemic heart failure. So total we had around 365 patients who had like deterioration because of the acute MI and worsening of the ischemic heart failure. And if you compare with the rest of the population of patients, like we have operated more than 2000 patients with the ischemic heart failure. So this is a fraction of the patient who had deterioration who had to be done in emergency. And most of the patients who come to us, they have like they are cash patients. So the main problem before doing the surgery, the logistics, because they don't have the funds ready, and then we have to take the risk of doing the surgery also. And like most of the patient, you have, the Euro score is shown on the top. Like up to 4 is considered like acceptable risk for surgery, and above 4 is a high risk, and above 8 is a very high risk. So here we have done surgeries in patients also who had a Euro score of more than 60 to 80. So when you do surgery with such high risk, because there is no other option, like they are not suitable for PTCA, and if you give them medical management or just conservatively treat, they are having a 100% risk of mortality. So when we operate these patients, then we saw that like initially, like if you compare in the first 10 years after we started off-pump surgery, those patients who had 5% risk, like in the next 10 years, their risk was 0%. So in these patients, 365 patients, those patients who had a Euro score up to 3 or 4, they had a 0% risk. Even up to 5%, they had 0 risk. And those who had a Euro score between 4 and 8, they had a risk of, in the previous decade, it was around 15%, and in this decade, like we had 2% mortalities. And then if the patient had a Euro score of more than 20, then the mortality was much less in this decade rather than the previous decade. And also we saw that the mean preoperative ejection fraction in those patients who had ejection fraction of say 15%, in the same group when we compared after 3 months and 1 year. So the ejection fraction mean was 32%. Some of them even had a normal ejection fraction, but some had like limited improvement in the ejection fraction, but the mean was 32%. And those who had a ejection fraction of 24% pre-op mean, they had a mean ejection fraction of 41%, and those who had a mean of 35 pre-op, they had a mean of 47 post-op, and those who had a mean of 44%, they had a mean of 53% post-op. So there was a significant increase in the ejection fraction of these patients. And then there was, when we studied the severity of the MR, So most of the patient who had severe MR, we prefer to optimize the MR medically with guideline directed medical therapy, and especially after the onset of ARNI, we have seen a much glaring improvement in the ejection fraction as well as the reduction in the MR after giving them optimum guideline directed medical therapy. And it was seen that there was significant decrease in the MR in the post-operative period, and most of the patients, they had either no MR or trace MR when we did the echo after 3 months and 1 year. Also, if you compare the length of stay in the hospital, it was seen that in the first decade we had a mean of 5 days post-op, and then now in this decade we had a mean of around 3 days in the hospital. So there was a significant improvement in the mean length of stay after the surgery. And for those patients who had a high Euro score, they also, if they had a, like in the previous decade, it was a 7-day length of stay, it has now become 4 days. And those who had a 10 days stay, like for Euro score up to 20, they have now a stay of almost half, like 5 days. And those who had above 20 to 40, again the length of stay was only 8 days, and those had more than 40 to 80, so the length of stay was almost 12 days. That was almost half of the length of stay that we used to have in the previous decade. If we compare the expected versus the observed mortality rate also, there was a significant improvement in the survival of the patients also, even in Euroscores as high as 80%. And it was seen that we had 3 mortalities out of 365 patients, and it was seen that out of these 2 patients, they had acute renal failure. So acute renal failure was one of the most important indicators, mortality indicator. And also it was seen that these patients also had moderate MR, there was severe PAH, and also most of the patients, they had diabetes mellitus. So these are all those comorbidities which may be a cause of mortality in such patients. And if we compare the previous decade, you can see in Group A, this is the decade from 2000 onwards to 2014, and then this is the Group B, which is from 2014 to 2025. So there were almost similar patients, like 1000 patients and 1000 in Group A and 1263 in Group B. So it was seen that in Group A, in the previous decade, we used to do more perfusion assisted bypass, like we used to sometimes put the patient on pump, or sometimes patient used to on table get converted to on pump when previously we started off pump. And the number was 17 in the previous decade, and now it is 3. Like we had only 3 conversions. And also it was seen the number of female patients who came with heart failure and decompensating heart failure, they were more in Group B. Like in the this decade, more female patients were present in the group. And also we have seen that the incidence of VT and VF were less, and fatal incidence or incidence requiring CPR was less. And then incidence of renal failure, acute renal failure was also less in this decade. And also it was seen that the patient who required mitral valve repair or replacement, they were also less in this decade. So we tried to optimize the MR medically rather than doing a mitral valve replacement or a repair. And also it was seen that the inotropic requirement was also less, IBP requirement was also less, and also the ICU stay, length of stay in the hospital, the mortality was also comparatively almost 1/4 of what it used to be when the surgeries are performed on pump or on perfusion assisted. And we have seen that in the last decade the number of re-intervention required also very less. And though less patients, very few patients, they come for PTCA or they come for I don't remember any redo surgery I had to perform in the last decade. So most of the patients, they recover well, but we have to make sure that we give the guideline directed medical therapy, and we always work as a team with the cardiologist. So if we do this comprehensive management, then the outcome of the patient is very good initially also, and also in the long term also. So with that I would like to conclude my talk, and I would like to request the audience that if you have any queries, and Dr. Naveen is with us, so I welcome Dr. Naveen. So thank you so much for sparing time. Good evening.
Pleasure to be here.
Same here.
What's your experience with the ventricular septal rupture? How many, when do you take them up? Because recently we had a case and we were in a dilemma because that case, that VSR was just about a week old.
Okay.
So what is your approach to those patients who come with recent MI and VSR? What do you recommend?
So actually, this is one of the dreaded complications, and like if we compare, we used to have more ventricular ruptures in the previous decade and very less in this decade, mainly because I think the patient, they were given timely treatment, and the chances of ventricular rupture, they were less because they were optimized quickly. But the question is that the ventricle may be friable, so many times if you take the patient immediately, sometimes it is very difficult to repair because there is no strength in the wall, and you keep on repairing and it keeps on tearing. So sometimes we resort to the natural selection that we put a IVP and we see whether the patient is stabilized, and once the initial stormy period is gone, then maybe the patient may tolerate the surgery in a better way.
Dr. Deepak, we know each other since our first year MBBS, but listening to your lecture for the first time and the type of dynamic scenario you have shown previous decade versus present decade, I think first of all it appears that now we are in the safe hands. Our chances of going through all the expected conflict and the dreadful, the type of cases you had and the outcome you gave is really phenomenal. It's excellent.
I think I would like to thank my cardiologist because like we really need their support. So it is not a single person's job, it is a teamwork. So we have to.
I think it is the team, it is the time, it is the equipment, it is the technology, everything advanced, but at the end the things are really exciting and wonderful.
Definitely, because we started Cardiomersion in 2011, and since then we have been promoting team approach. And incidentally, in the same year, American Heart Association also, they put it in the guideline that the management of cardiac patient should be by team approach. So I find team approach like we have hit the bullseye, that we don't have the onus of responsibility on ourselves only. It is divided between the team, and even the cardiac anesthetists play important role, intensivists play important role. But the main role, we go together with the cardiologist, because without their support, I don't think we can achieve such good results. So many times we send the patient to a cardiologist that MR is very severe and risk of surgery is high, so they open up the culprit vessel, MR improves, and then later on we do the bypass surgery. So I don't believe in holding the patient. If the patient can be benefited by percutaneous procedure, then definitely I would refer the patient for a percutaneous procedure rather than forcing the patient to undergo much higher risk procedure. So it is understanding with the cardiologist. Sometimes they refer the patient to us that this patient will be more benefited by surgery rather than PTCA. So with that kind of understanding, like if we give the best to the patient, then definitely the outcome improves. Thank you very much, and I think would like to hear the next talk from Dr. Naveen. Thank you so much.